So my name is Kathryn, but Kate. And we're the trauma, burn, sort of eking into other areas available child life program. I wanted to sort of go over like who we are and then like what we can offer for you guys now that it's been sort of formally allowed for us to branch out. So child life. So a child life specialist is a master's prepared trauma-informed child development professional. So in addition to a master's degree, all of child life specialists have to do a 10-week practicum where they shadow a child life specialist basically, and an internship where they learn to work independently. Ayumi's my practicum student right now. Unfortunately, today is her last day. And Claude is my intern, and she'll be with me till January. And Winnie's our therapy dog. And so at any given time, we have 2 to 4 students. I've created a system where we all have to wear uniforms, so nobody's worried about who's seeing their patients. If you see a pink shirt, it's okay. They've been vetted. They've gone through our service, getting into the system. We've gone through new employee orientation, the whole bit. Our interns can chart in Epic, so they're allowed to work independently of me. We're one of the smallest child life programs in the country, but we currently have the largest education program. For comparisons, Children's of Los Angeles has 40 child life specialists, and they only take 1 student a year. We take about 12. Yeah. So the American Academy of Pediatrics says that child life programs are essential. So if you see kids, there should be some sort of child life base. I pulled the trauma numbers from 2015, and you guys had 200 pediatric admissions. So there's definitely a need. Let's see. Our current mission statement is to provide support, education, developmentally appropriate play opportunities, and school intervention, in addition to facilitating outreach and injury prevention education. So we do go into schools and teach a lot of the stuff to keep them from ever having to come to us in the first place, whether it be burn prevention or injury prevention as far as crossing the street and wearing helmets and all of that. So basically we provide psychosocial and emotional support that's a little different from the standard social work or psych sort of perspective. We address every kid. There doesn't need to be a psychological issue to address, and there doesn't need to be a social issue with the family or anything like that. We basically see that there's a need. If there's a child in the hospital, that's enough to warrant a need for child life intervention. So basically, God bless you. We work to provide as non-threatening an environment as possible. And we are technically a non-pediatric hospital, which we all know is not really true. And so we work to sort of provide opportunities for these kids to be kids, for kids to ask questions. They might feel sort of the need to say, yes, I understand what you just told me, but maybe they have no idea what was just told to them about upcoming procedures or surgeries or anything like that. So we help with that. And we also work to identify their pre-existing coping skills. So if they already have things that work for them, if certain music, certain movies, certain comfort items, and I'm talking all the way through teenagers. I mean, we have 20-year-olds in the burn unit who want their teddy bear. So whatever that works for them at home, we try to find a way to sort of bring that to them in the hospital so that we can build on what they already have. As you've probably all seen, that we have some kids with 0 coping skills, and in that case, we try to instill some. So this is what we currently can offer. So medical and therapeutic play, which I'll get into a little bit. Non-pharmacological pain and stress management. So we have all different kinds of things from different meditative practices, guided imagery, and all of that. We're a little careful on burn with guided imagery because they are on so many pain medications that we don't want to cause any sort of hallucination-y sort of situations. But it can be a little different if they have a different kind of pain control. Support and distraction during medical procedures. If you have someone that's super, super anxious, we can be available to be with them during whatever. And nothing is too small. If they're afraid of having an IV put in, we can be there for that, all the way to any kind of invasive sort of procedure that we can be present for. And the big thing for you guys will also be, we're available for the children of adult patients. So if you have someone who's experienced a major trauma and the child has to somehow come see the parent, visit the parent, the other parent reports there's anxiety about what's happened to the hospitalized parent, we can help facilitate that. And we do a lot of that with burn because obviously the parent might look very different now. But it can be the whole range of things. If the child has witnessed the accident that brought them to your unit, anything like that, we can help. We do have the therapy dog. She comes about once a week, but she can come as often as is requested, so let us know. Patient advocacy, special events and activities, we do go to the schools, and grief support. So if you do have a patient, we do work with palliative care as well. So if you have a patient that is going to pass and they have children, or if they are the child, we can help with that.
So if we had, I'm sorry.
Oh, absolutely.
If we just had a patient that was dying or wanting to see like, grandchildren and people, sometimes families don't know whether it's appropriate or whether they're kids, so we could call you
Absolutely.
guys. Oh, perfect.
Absolutely. So the big thing with the bereavement piece is that if it's a close family member and it's a traumatic loss, we always encourage, if at all possible, for that child to be able to get in there and say goodbye. Everyone's very worried about the trauma of seeing the patient or being around the patient, and that's a legitimate concern. The reality is, though, the trauma of a sudden loss with no closure carries much further. We can't explain that away. We can explain what happened to the patient, why the patient looked the way they did, and we do a lot of prep before we bring them into that environment. And when we know the patient is either on comfort care or death is imminent, there are things you can do in that room to make it a little less intense that you couldn't if you were trying to sustain life. So there are lots of things we can do, but I'm a very strong proponent of if they can get a good buy-in, it's important. It doesn't always work, but we try.
Are you 20 hours?
So right now, we are 4 days a week. We are 7 days a week starting September 14th. And we're 10-hour days, 7 days a week starting on September 14th. I was that a few weeks ago, but my other specialist had a baby, so she's gone for a little while. But she'll be back in September and we'll be available. And our hours are consistent, usually 7 to 5:30, but we can, if you know there's any special case, like we're talking about bereavement, there's something that's coming up, we can adjust however anybody needs us to. We're pretty flexible like that. So this is who we can serve for you guys. Anyone up to 18. In the burn center, we go up to 21. We can go up to 21 for you guys, but sometimes it's just not appropriate. At that point, social worker or psych might be more appropriate. Children and the siblings of patients, and then adult with developmental considerations. Right now we're working with a couple of your patients who have TBIs. We can do that if the circumstances warrant it. So if they're still functioning and they need some sort of stimulation or some sort of interaction, socialization, things like that, we can totally help with. If the situation is so severe where we're getting punched, hit, and we can't really do much, it doesn't really warrant it. But if you guys see a need, we try to meet it. So again, kind of reiterating, promoting the coping skills, and then for your adolescents that you see, we're trying to facilitate the continuation of typical adolescent development and family-centered care. So we have all sorts of things from expressive activities where we can literally bring pretty much any kind of arts, craft, or whatever you can imagine we have. Sibling support and education, and we try to get things where if they have friends, we try to create an activity that they can do with their friends, either a game or even video games. We have those sorts of things. If their friend comes to visit, we can have them all be together, because the socialization is the biggest part. And then the siblings and children of adults. So the preparation part that we talked about, and preparation can go all the way from we sit in a room, that child's nowhere near the parent, and we talk about why the parent's here. They get to meet the nursing staff. They get a familiarity of what the hospital environment's like, where mom, dad, grandma, grandpa, whoever is, all the way to preparing them for what they're going to see if they go into the room. I will say about that is if there isn't the threat of an imminent death, we try to wait till the parent or relative is far enough along that we don't cause undue stress and trauma. It's not always a perfect situation, but if we can have either phone conversations or things like that, or even they can leave a message and they feel like they're involved, we try to start that way. If the idea is that the patient is going to get better, we try to wait till they're closer to better before we bring them into maybe the SI or someplace that's a little intimidating. And again, education, family bonding, so if they're here for a long time, trying to create environments they can watch a movie together, they can do some sort of activity together, and then grief support like we talked about. And grief can also include if a parent has lost a limb, parent has changed their body image, if the parent that came into the hospital is not the same as the parent that is leaving the hospital, that's a loss, so we address that grief the same way. I'm sorry, I'm talking really fast. Just interrupt me if you need to. So the adolescent vulnerabilities. So the biggest thing that we've seen is kids that people think are doing okay because they're not acting out and they're not being pains in the butt and verbalizing their needs and concerns. Because a lot of times those kids are the ones that are having the most stress. The kids who aren't getting the opportunity to verbalize what they're worried about, they're a little afraid to ask questions, things of that nature. So they're not always doing fine. The other thing is trying to address things such as the invincibility, the peer pressure, and all of the things that make adolescents candidates for a trauma department. We try to address once they're with us. So sort of addressing what brought them there. Are there anything we can do going forward? Is this something that has been a consistent risky behavior? Is this a result of I'm 16 and I'm drinking and I got in an accident, or was it just simply an accident? So we kind of address that as it goes along. And then this is a little bit more. So the big things we address with peer interaction, body image, and self-sufficiency. So if we can address those three things in adolescence, they do a lot better long term. And hospitalization actually becomes an area of growth for those children. It becomes a place where they develop into stronger, more independent people. They feel empowered. I mean, it was awful, they don't want to go back, but it gives them an opportunity for character development, for personal development, for their own personal growth. And so if we can address the fact that maybe their body has changed, is this permanent, is this not permanent, is the perception of it permanent, the self-sufficiency is as much as we can get them participating in their care, and then the peer interaction if at all possible. Even if we have to bring in the iPad and have them Skype, we do that as well. Medical play, you guys will see us do this more with the children of adults because most of your kiddos are going to be a little beyond this. But we bring in a lot of the things that they would see in the room, see with their patient, with their parent, their grandparent, whoever it might be, and let them manipulate it. This is in actually my office right now, but we have blank cloth dolls. They can create the doll. We can kind of get a sense of their perception of what's happening. Great, but a perfect example is we had a very anxious little kid who everyone thought was afraid of her dressing changes. We let her play with medical equipment, we let her play with a doll, and she strapped every single thing we gave that doll to its face. She is not worried about the burn on her leg at all. She didn't like going under anesthesia, and she didn't like the mask. As soon as we started sharing that and expressing that to the anesthesiologist, they did the induction through her IV, and the solution was simple. It's not always that simple, but it was something we were very convinced, everyone was very convinced she was terrified of wound care. Well, she was terrified of falling asleep for wound care. So we sort of do that, and it allows the kids, when they play, they will tell us what's actually freaking them out, more than they will if you're like, what are you worried about? They honestly don't always have the words. So for the patients, it helps us to prepare them, and for the siblings and children of patients, it helps us to get a sense of where they're at and teach them what they're going to see and need going forward. Surgery and procedure support. So a lot of times we will, well, with all of our burn kids, we do this, but with your kiddos, we can go and sort of do a follow-up. If we know they're going to go to a surgery, especially if it's something major, and just have them reiterate back to us, like, what do you think is going to happen today? Like, what do you know is happening? Like, what is your perception of what's happening, so we can clarify in case they've said, yeah, I know, and meanwhile they're having little anxiety attacks, but they don't really. And then provide comfort in different things in the hours before. We're about to launch ourselves into pre-op and PACU in the next 6 months, so we'll be present for them for that as well. So we'll be available for that. If you see a kid in your service that's anxious about surgery, we can arrange to be available for them for that.
So are you like a consult, or you just pick up the phone?
Yeah, so right now, all you have to do is pick up the phone, and I actually have cards for you. You can pick up the phone and call us. The other thing is at this very moment, I'm working with Epic to make a order. So you guys, anybody who wants us can just put in an order and we'll get it. As we're expanding into the entire other campus, it's becoming a need. I don't know if you guys know where our office is, but we're literally smack in between the middle of the 5th floor, right next to the elevators. The door is almost always open, so come on by. But yeah, we're available, just either phone call, email. I'm personally on my email all the time, it's unfortunate. And will respond very quickly. And if you leave a message, we'll respond as soon as they come back. If we're not there, we're just with a patient.
Are you guys here 24/7?
No, we're here 10 hours a day. But like I said, we can be very, very flexible with that. So if there's something the only thing is preparing in advance. So if you know something, we can't be there for an emergent trauma in the middle of the night. But if you know an emergent trauma came in the middle of the night and you send an email, I can come in early, I can stay late, I can do whatever anyone needs to do. And so can Alyssa, my counterpart. That's sort of our deal right now. At the moment, we're trying to prove that there is a need for more of us. So I will do whatever it takes to prove that.
Are you on the paging?
I am, but again, we're working on fixing that as well. She sent me a message. I will probably get it in an hour. Something is wrong where I'm not getting my my text messages on my pager at the right time. So they're working on that, unfortunately. And this is sort of our expressive art. So this is a little bit of what you'd see. If you see us running down the hall with arms full of paint, sand, musical instruments, what have you, that's why. Let's see. Where you gotta go? I want you to go. Oh, there we go. And so my background is my bachelor's degree is in social work, my master's degree is in marriage and family therapy, but generally that's not the case for child life. So instead of saying therapy, we call it therapeutic dialogue, therapeutic play. And again, sort of in the line of with the doll, we let them sort of express themselves in any way they want. If they want to beat the crap out of this particular Play-Doh ball, then great. As long as they're not doing it to you guys, right? That's sort of the goal. And we try to get them to express their fears and concerns in a safe way so you guys have a better experience taking care of them and they have a better experience being cared for. And then the same thing, sort of coping skills facilitation. We do have, and we can make available to you guys, the About Me posters. So we can list what works for them. We can work with them to put on there what they need, what they want, what they don't like, what will trigger them, things like that. So they can be available if that's something you're interested in. And trying to promote healthy coping strategies in lieu of maladaptive coping behaviors. And then play. So the best part of our job is we get to play with kids all day. These are sort of some of the statements on play from the American Academy of Pediatrics, but the United Nations High Commission on Human Rights has declared that play is the right of every child. So if there's a child in this hospital, whether it be a patient or the child of a patient, we try to provide opportunities for them to be kids and be as normal as possible in a relatively abnormal environment. And that's sort of our mission. So along with everything else, we try to integrate sort of therapy and prep and all that stuff into it, but the foundation of everything we do is play-based. And these are some of the things we've done. So we do outreach with our kids. So we follow our kids basically forever. And 3 times a year, I take groups of kids to theme parks and museums and things like that so they can build a survivor community. I don't know what that would look like yet for you guys, but trust me, I'm already thinking about it. I work very hard to get donations. Everything I do is donation-based. We don't really have a supply budget, so everything you see is something we've convinced a family to donate to us. And our little armadillo friend in the middle, which is something we can offer to you guys, at the end of October, we have the Zoo Express come to the hospital with the zoo animals to visit with the patients, adults and pediatrics alike. So if I will send out an email when that day happens. It is a Thursday. I cannot remember the exact date. Do you remember on the calendar? Maybe the 26th. But the zoo will be coming with the animals on that day. And they're going to start coming quarterly. And then one of our most recent trips was to the zoo. Our little kiddos. Yeah. The kids got to hug this guy. It was very nerve-wracking for me. I was like, I'm going to have to go home and tell these parents where their children are. They trust us, but I'm like, oh my gosh. Right now, like I said, we're available 4 days a week. Ayumi's going to give you guys, I created little badge thingies with the pain scale on it and all of our contact information on the back. So you guys can have those to use, if you will. Yes?
Are you only here or do we share you in the hall?
You are just now starting to share me with La Jolla. This is brand new.
Why?
But it's in a very different context. I am available to your inpatients. I'm not available to theirs. I'm available just for palliative care for them. So I work in their outpatient palliative care clinic with their families. So I help facilitate the conversations about end of life with parents. We will be there more as we go into pre-op and PACU. But right now it's only in this context of outpatient palliative care. So it's appointment based. I'll go up there for like an 11 o'clock appointment and then I come back. Yeah, I'm telling you, when I say I will be wherever to prove the point of this, I will be. So I'll probably be nothing but a little nub by the end of the year, but we're working on it. Any other questions? Okay, perfect. Thank you guys.
Thank you.